All right, good morning, everyone. We're going to start in just a moment, so I'd like to ask you to take your seats. I think we've got just about everybody here. I want to thank you all for coming today. I'm Mark McClellan. I'm a senior fellow and the director of the initiatives on healthcare innovation and value at the Engelberg Center for Healthcare Reform at Brookings, and I'm very pleased to welcome all of you to the 7th annual Sentinel Initiative Public Workshop. That's 7. We're very pleased to be joined today by leading experts in government, industry, academia, health systems, patient advocacy, all for a productive exchange about the recent developments in the Sentinel Initiative and next steps for this important and increasingly established program. As many of you know, the Sentinel Initiative began as a result of the passage of the Food and Drug Administration Amendments Act back in 2007. And that act mandated that the Food and Drug Administration develop a national electronic system to track the safety of regulated medical products. And in response to this charge, FDA launched the Sentinel Initiative in 2008. Mini-Sentinel, which was the pilot version of the Sentinel Initiative, utilized electronic healthcare data from existing health insurance claims and other electronic clinical data collected by participating data partner organizations to form the basis of the surveillance system that made up the Sentinel Initiative. And this initiative's distributed system is comprised of quality check data, carefully turned into comparable data by 18 partner organizations working together under the Mini-Sentinel pilot infrastructure. And as a result of these successful partnerships and the leadership of the FDA in continuing to support this program as a collaborative effort with many private sector partners, the Mini-Sentinel pilot has surpassed its goal of 100 million covered lives that was originally put forth by Congress. That was 100 million by 2012, and as of July 2014, in fact, the Mini-Sentinel distributed database system contains data on 178 million individuals, representing almost 360 person-years of observations related to drug safety surveillance. Sentinel has established the infrastructure for conducting rapid active surveillance in near real time on this data system. And that infrastructure has also allowed the Mini-Sentinel analysts to conduct more in-depth protocol-based assessments using data from a significant part of the U.S. population. The development of this program, the development of the Mini-Sentinel program, marked an important expansion of FDA's capacity for post-market safety surveillance with the potential for delivering more rapid, more comprehensive and certain, and therefore actionable information to inform regulators, healthcare professionals, patients, and the public. After 5 years of successful piloting, the Mini-Sentinel program is now transitioning into the full-scale Sentinel system. Today, we'll have an opportunity to hear from a range of key stakeholders about what this transition process will look like and what the future holds for the Sentinel system. It's an infrastructure that's not only being used for safety surveillance now, but this principle, this approach to distributed data analysis with sharing key summary information, but not the underlying private data, is a potentially generalizable model for addressing other key issues around medical evidence from actual medical practice. And we'll be talking about some of the opportunities for Sentinel to become a national resource, not only for safety, surveillance, and research at the FDA, but for other researchers and other analysts as well. And then looking beyond issues related to safety, we'll also spend some time discussing other potential extensions for this kind of Sentinel infrastructure, exploring ways that it could be a shared national resource, enabling other evidence development relevant to the public policy questions and issues that we're facing as a nation in public health surveillance and quality improvement and other aspects of clinical research. So that's a lot to cover today. I'd like to quickly go over the agenda. We're going to begin with a keynote address from Janet Woodcock. Then we'll open things up for our panel. The first panel will have a discussion of where we are with the current state of Mini-Sentinel and now Sentinel activities. It'll include Richard Platt kicking it off with a presentation of the current state of Mini-Sentinel and look forward to the future endeavors that the Sentinel team is working on. Then our FDA panelists, Marcia Reichman and Michael Nguyen, will present an overview of how Sentinel is being used to inform regulatory actions within their respective centers in drugs and biologics. And then after a short break, our second panel is going to focus on stakeholder perspectives on the future of the Sentinel system, its uses so far and what that portends for the future, and ideas and issues that they'd like to talk about as we move into this next phase of the Sentinel Initiative. This session is going to explore some potential approaches that FDA and other stakeholders might consider to strengthen post-market safety surveillance as it transitions into the full Sentinel system. After a break for lunch, the final session of the day is going to focus on the broader future of the Sentinel Initiative. Panelists are going to discuss opportunities for expanding Sentinel to strengthen post-market evidence generation capabilities, for example, by supporting public health surveillance, analyses of quality of care, facilitating clinical studies of other types. And I want to emphasize that this is intended to be not just a way for you to hear about what's going on from these different perspectives of individuals, groups that have been involved in the Sentinel Initiative and plans for its future, but also an opportunity for thoughtful questions and comments. So we're going to have plenty of chances for comments and questions from those of you who are here today. This is obviously an open meeting. Press have been invited. The webcast is being broadcast live online, and welcome to all of you who are joining us online and are missing the cold weather here in Washington this morning. So everything you say is going to be part of the record. For the panelists, we have a timekeeper up front, Serena, who's sitting right there. Hi, Serena. And we'll let you know how things are going with respect to your allotted time. And for all of you who are attending, again, we really appreciate your being here, and we want you to ask questions or make comments. We'll have parts of each of the session for that kind of open discussion. And there will be microphones in the aisles for you to use to speak. During the breaks, we've got coffee, tea, sodas, water in the back of the room. And also lunch will be on your own. There are a number of restaurants very close. There's a dining guide on the registration table, so if you want guidance from that, please grab one before you head out for lunch. And also please know that if you want to bring food back in here afterwards, that's just fine as well. So that's an overview for the day and some of the logistics for the day as well. I'd like to get right into the action for the meeting with our keynote speaker. I'm very pleased to introduce Janet Woodcock, the Director of the Center for Drug Evaluation and Research at the Food and Drug Administration. Janet's been an instrumental force in developing the Sentinel Initiative, the vision, and making sure all of these logistics with all of the different stakeholders who are involved come together to carry this out and reflect their shared perspectives. This vision has really helped Sentinel develop into a tool that can not only be beneficial for the FDA, but can help us well on our way towards a learning healthcare system. Janet?
Thanks. Thank you, Mark. Good morning, everyone. Yeah, I may have a case of sniffles, too. It's really cold out there. I want to thank you all for taking the time to participate in our 7th annual Sentinel Public Workshop. This is really becoming quite a legacy here that we've been doing this so long. It's hard to believe, though, how much has been accomplished in the past 7 years. Those of you who are with us at the beginning, I think none of us would have imagined we would have gotten this far. And this project truly is an example, I think, of the benefits that can be achieved through broad collaboration. And I'd really like to acknowledge Mark McClellan for his role, because, you know, if he got this in the statute, and I know you did, and if that hadn't happened, you know, we wouldn't have had the impetus for all these accomplishments. So really appreciate it, Mark, and it has really paid off. So we've worked over the past 7 years on with many people to develop the scientific approaches, which have been tremendous challenges, of course, that are ongoing, but also to develop the needed infrastructure and the governance. And I think the careful attention by the team in the Office of Medical Policy that was the incubator for this to the governance issues has really helped in the transparency and really working through all these issues with the stakeholders so everyone knew what we were doing from every point of the way, because I think there is always concern about the use of individual health data and so forth. So the work of the Sentinel Initiative is one of the first examples of a large distributed active surveillance system of real-world data that can be used to better understand the performance in the real world of drugs, biologics, vaccines after marketing. And these data we found, and we didn't know this at the beginning, but we found they really can inform regulatory decisions. They're not deal breakers one way or another. They're usually not determinative because of still the various uncertainties around these data, but they can tremendously inform us, and very important for me, rapidly inform us, which was not the case before. So that's really tremendous progress. We have to continue to invest, though, in activities to understand how to harness the data to inform us more and more about the safety of medical products. And that investment in research really, I think, is about, like, how can we make these data more reliable, more robust, so that we can put more weight on the data going forward and understand where to appropriately put weight on the findings and where the findings and why the findings might be confounded in one way or another. The achievements of Sentinel were deliberate, and they were very labor and time intensive, and I really do salute the people who's worked on this. It's been a slog for a very long time, a very deliberate slog. There was extensive research and methodologic development that allowed us to understand how at this point we can use the data and along with the other information we have on a product to help provide patients and their providers the important safety information they need to make healthcare decisions. And I think this is becoming more and more important in this day of, like, media frenzies over anything. We can go out and we can find out what's happened. 178 million lives is a lot of data, and so we can really look in the real world and say what has happened. And before, we would get signals and we would be blind to that. We'd have to do a study, or we wouldn't know what else had happened. And you can see the potential of this in the future as more and more records become in the electronic world and we can access them. We can actually tell what is happening to people and reassure them or take swift action if needed. But the breadth of Sentinel also continues to grow because there are different types of data available. And although we started with one type of data, primarily the claims data, we can broaden that and link it to other healthcare data that are available out there, and that could really help us understand things better. But I can't stress enough the data itself isn't sufficient. We have to continue to invest in how to best use these data. Through Mini-Sentinel, the Mini-Sentinel project over the last 5 years, we developed analytic methods that are used for safety surveillance and allow rapid responses to our safety questions. So we have to make sure, though, that we have a robust sort of portfolio of these analytical methods, because each problem is different, and the way you approach different safety problems analytically must be different. And right now we have a limited portfolio of questions we can rapidly answer. So we'd like to expand that portfolio to a lot of tools. So, for example, we can see safety problems that in people who've had short-term exposure, who've had chronic exposure, or the outcome could be sort of have a secular trend and get worse over time after exposure. There are all these different scenarios that we need to follow. And there are many other characteristics that I don't understand because I'm not a pharmacoepidemiologist that have to be taken into account, in answering these different questions. So we need to have different methods available that are fit for purpose. And that means we have to transform the tools. We have to develop them, make them a research tool, then transfer them into a production tool. because the production tool is a tool that can be picked up and used very rapidly and get that information back to us. And we're working through the IMEDS project and with other stakeholders. Of course, we continue to work on these analytical methods. Now, you're going to hear about the significant contribution and achievements of Mini-Sentinel the last 5 years from Rich Platt from our Operations Center at Harvard Pilgrim and from FDA staff who will be on this panel. So I'd like to spend the rest of my time focusing on the future, what's next. Namely, the transition from Mini-Sentinel right now to the Sentinel system. What's that going to look like? Mini-Sentinel has become an important part of our post-market safety surveillance capabilities. So it's become another component of what we have. We have the adverse event reporting system, we have other type epidemiologic studies we have, and we have Mini-Sentinel. The information we get, as I said, from Sentinel is used to complement the other data that we have from pre-market and these other sources. And through Mini-Sentinel, it was a feasibility study. We showed we can obtain rapid responses to these signals, these questions that arise. They pop up after marketing and get everybody in a twist, and we can actually have some kind of approximation of an answer of what's happening in the real world. But we now have to take the success of Mini-Sentinel, this proof of concept, these things that it's done, and translate that into a fully operational Sentinel system. Now, the first step occurred when we, in September of 2014, we awarded a contract to Harvard Pilgrim after competition to transition from Mini-Sentinel to Sentinel, a sustainable active surveillance system. And this transition is currently ongoing and focuses on establishing the policies, procedures, and organization for the real Sentinel system, and also broadening its reach into other types of data. So there are different types of data available. So we look for opportunities to enrich the quantity and enhance the quality of the data that we can get. We must consider how to bring those that have unique data characteristics that haven't been part of our collaboration into Sentinel. And this includes other federal partner data sources, which we are talking to. And we've had the federal partners collaboration as another part of our sort of Mini-Sentinel concept, but those were all kept separate at DOD, VA, and even the CMS data. And so we are having conversations about how do we integrate that a little bit more tightly, either as part or as a continuing parallel system, okay? We also need to expand the types of data. We know that as electronic health records are standing up more, that's a tremendously rich opportunity to get more information on the individual, what happened in individual cases. However, there are tremendous issues about how do you extract that from these disparate electronic health records and disparate ways that people have written down things and so forth and so on. So, in other words, there's a lot of work to do, but that obviously is one of the tasks for the next 5 years, to make the electronic health records well integrated in the system. And we're also looking for other opportunities for data that can really tell us more things than we can find out now. For example, we're exploring linking with the CDC's National Death Index to ascertain a cause of death for out-of-hospital deaths, because right now that isn't in the claims data if the people didn't die under health care. So we have to find that out a different way. And the Sentinel Common Data Model, which has served us well and has been adopted by others, we need, as we incorporate new data, we have to see how fit for purpose that model is to accommodate all these other data types and new data partners. And we'll continue to keep working on the Common Data Model and getting it to the next level iteratively as we add other data sources. An organization also, we need to take a look at our governance, including the principles and policies that have actually served us extremely well over the last 5 years, and see if any of those need to be updated as we have really a true production system. So we have to also consider, as we upgrade and strengthen the Sentinel system, how we in FDA utilize this tool in the context of our other safety pharmacovigilance tools I already talked about. And so we plan to more fully integrate Sentinel into CBER's pharmacovigilance programs. And to do that at CBER, we're going to transition the management and development of Sentinel from our Office of Medical Policy, which was the incubator unit that stood this up, to the Office of Surveillance and Epidemiology. I always forget what that acronym means. Yeah, so that's our safety office. Okay, so we're going to transfer Sentinel into the safety office so that we can institutionalize the use of Sentinel as part of our safety toolkit. And it can be, as we get a problem, we see a problem, the OSE is dealing with myriad, of course, of safety signals at any time. This is one of the tools they can easily reach for in their toolkit. So this will really help us with pharmacovigilance planning, I think, and life cycle management at CBER. And we hope to have a seamless transition that doesn't impact either ongoing activities or future work, but enhances the way that we utilize this important resource. And there are many people from Office of Medical Policy here. I don't know whether Rachel Sherman is here, who was one of the principal architects of standing that up. But for all the folks from Med Policy, you've done a tremendous job of getting this going. And everyone, as I said, there were so many people who contributed to making this happen. But we commit to the public that we will, in fact, make sure this system remains robust, and we're going to have a full year to transfer it over to make sure nothing's lost in transition, so to speak. We continue to be committed to working to support the creation of a national resource. So what does that mean? Well, we have links to all these data. They've been standardized at the data partner level. We can access them. What about all the other uses for these data? People ask us about this all the time, but we built our piece of Sentinel as a safety system, right? However, that doesn't mean that other parties could not utilize the same data network for other research purposes or other types of purposes. That would help us, I think, because it would share the financial load a little bit, and I've long been seeking that. So we're making steps in that toward that goal. We're working with the IMEDS, which is our Reagan-Udall Foundation, the FDA Foundation, and it has a safety project that is also looking at how the Sentinel resource could be used by others outside to do research projects, among other things. And then PCORI, who shares a link through Rich Platt and others, and how can we work with PCORI, who has the goal of performing comparative effectiveness research studies. And obviously some of the ways our data are configured or so forth in our common data model may not be perfect for that, but as I said, we can iterate and improve that. But it would be better to do that than probably build a whole separate system to access the same data partners and make them transform their data yet another way so they can perform these other types of research. But not everybody agrees with that or is, on the same, we're not singing from the same songbook yet, but we're working on it. We've been working on this for 7 years, so we'll continue to work on it for the next 7 years until we get it done. So that would be tremendous because it would help, I think it would reduce the burden on the data partners, and it would enable everyone to work on the same research efforts to make sure that the data model and the analytical methods were fit for purpose. So there'd be tremendous synergy, but we could accomplish these various activities, all of which that need to be done are important. So it's clear we've come a long way, but we still have a long way to go. And this is a journey. We're going to be in production, but we're not going to stop our efforts to improve and get Sentinel to the next level and the next level after that. So one of the exciting parts of all the Sentinel activities is that expansion of our capabilities and capacity and methods will probably likely continue long into the future. And this is really, I think, starting a new kind of science that will be really rewarding and provide us so much more information than we had in the past. So it's been a great journey so far, and we look forward to all the work to come. We thank you all for working with us, and we hope to work very closely with the stakeholders in the future. Thank you.
Janet, do you have time for a question or two right now?
I'm going to stay for the
Okay,
panel.
great,
Okay,
great, and we'll build it into the panel. All right, so if I could have Janet does want to have some question discussion about this, but I think we're going to build that into the whole first panel discussion after you've had some additional further perspectives. I think will illustrate some of the points that she just raised. So I'd like to ask the first panel to come on up while I introduce them, and Janet will be back with us as well. So as you've heard, there's been a lot that has happened in Mini-Sentinel and now Sentinel since its launch. So for this panel, we're going to hear in more detail about what's going on now with Mini-Sentinel and this transition to the Sentinel Initiative from Rich Platt. And we're also going to hear from Marcia Reichman, thanks for putting your name card back, and Michael Wen. They're going to talk from a CBER and CBER perspective about how Sentinel is being used for regulatory actions and for informing regulatory processes within their respective centers. Rich is professor and chair of the Department of Population Medicine at Harvard Medical School and executive director of the Harvard Pilgrim Healthcare Institute. So we're going to turn to him right now for an overview of where we are and where we're headed. Thanks, Rich.
Thanks. Janet did such a terrific job. The only thing she didn't do was give a clear indication of her central role in framing everything that happened. But if you were here 10 and 9 and 8 years ago, it was really clear that this really emanated from so much of what you organized, Janet. So thanks. So as we're in the transition year, just want to do a quick reprise of sort of how we got here. We learned when we took on this project that FDA thinks about its surveillance activities in 3 buckets, and we spent the first several years of our work really in this central area, looking at signal refinement. When there's reason to suspect there might be a problem, could we rapidly provide information to FDA to help them sort that out? And we did that through a series of capabilities that we built to allow sort of rapid kinds of analysis. And over time, that also grew to include more sophisticated kinds of analyses that we call protocol-based analyses. Over the past couple of years, we've been developing the capability to do prospective analyses, monitoring products that are fairly new to the market as experience accumulates, with the idea of understanding as soon as possible whether there's important information that the agency would like to know about. And during the past year, we have started to develop a capability to do, I guess we should call this hypothesis-free assessment. That is looking for anything that might be a problem rather than investigating specific kinds of concerns that the agency might have. And that has largely been under the aegis of the Center for Biologics' interest in exploring new biologic products. I have to say, we surprised ourselves to find that during this period when we were a pilot project, we actually provided information that was useful to the agency in its regulatory decision-making, but we were very pleased that that was the case. There are 4 drug safety communications that emerged from the work that we did. And there were other ways in which we were able to communicate what we've done. A couple dozen presentations by FDA staff, dozens of methods papers, peer-reviewed articles, and a substantial number of assessments of medical product use and outcomes of their use. And sometimes the work we've done has made its way into high-quality peer-reviewed journals. So the ability to do the highest quality science while supporting the kind of time requirements that FDA has been something that we've really tried to be attentive to. And we were pleased that we've gotten some notice and sort of favorable response in the wider literature. This is a perspective that Bruce Bassetti authored. Bruce is here in the audience. Thank you, Bruce. And this is probably the right point for me to say. In past years, I've ended my report to you by sort of rolling the credits of the people who've been involved in Sentinel, and I can't do that this year because we've reached the tipping point. There are too many people. The work that we have done and are doing really is the product of not only of a great FDA staff who've teamed with us, but literally hundreds of investigators in dozens of organizations who are really deeply committed to this activity. And so they really deserve a shout out. A number of you are in the audience today, and it's great to see you here and to sort of be able to observe how much progress we've made. I do want to mention there are 3 people from the Operations Center here. That's Jeff Brown, Nicola Beaulieu, and Jen Popovic. So if you want to talk to people who are sort of doing this every day and in the Operations Center, they're here, and I suggest you seek them out. The 3 of you just raise your hands so people know where to find you. Okay, Jeff's in the back row if you want to go around. Okay, one of the things that FDA said at the very outset was everything you do becomes public at the right time, and the right time should be as soon as possible. And we use the website as our primary communication vehicle, even when that means not waiting to go through the ordinary peer review process. Something that for the academics in the environment does, ouch, we said. But it's a good resource, and almost everything that I say today that has to do with results or things that we're doing is on the website. These are the organizations that are currently participating in Sentinel. I want to point out the changes from last year. First of all, WellPoint, which is the partner with Health Corps, has a new name, Anthem, and Marcus Wilson's here. He'll be speaking later today. Hospital Corporation of America has joined Sentinel, 160-bed hospital chain, bringing a whole new useful kind of data to Sentinel. Carla Miller is going to be speaking, is at HCN, will be speaking later as well. And Blue Cross Blue Shield of Massachusetts is also new here. Let me talk briefly about basically 3 domains that Sentinel works in. One is in developing data that's fit for purpose. The second is in, as Janet said, making the methods be fit for the data and the environment that we work in. And the third is actually doing something that yields useful information. In the data environment, Mark stole my thunder here. We've created a distributed database that has quite a lot of analysis-ready data. That's really been the stake in the ground. The data is ready to be analyzed, so an enormous amount of work goes into making it ready to use, and that has served us well. The platform has been administrative data, and we did that for a number of reasons, not least because this is the platform that allows us to know what the population at risk is. It's critically important to know that if somebody was exposed to a product and had an outcome that we cared about, that we would be able to find it. And you can find it in this society at this moment by saying, if we know who is going to pay the bill, we have a reasonable chance of being able to find it. As Janet mentioned, we're working hard to get electronic health record and laboratory data. We have it for about 10% of the population. We have some of that data for about 10% of the population. And we've been working to link where necessary to other sources of information like birth certificate data and immunization registries, which are state-based. And finally, one of the critical pieces that was baked into the origins was, although administrative data is the large platform in which we work. It's not sufficient by itself to address many important questions. And so a criterion of being part of the system was, when necessary, it'd be possible to review a full-text medical record to confirm an outcome, for instance. And we've done that in a way that's, that redacts personal information so that we can get the information we need without disclosing identities. The data lives in a common data model that we developed in a consensus process with our data partners. It's a series of linked tables, which you can see here. It's not all the data that lives. It's a tiny fraction of all the kinds of data. We've followed the policy that you can answer, I don't know, 75, 80% of the questions with 10% of the data, and that allows us to really focus on making sure we understand what these data elements mean. There are several people in our operations center whose full-time job is to work on data quality assurance, and they partner with people at each of the partner organizations to review the data. Every time the data is refreshed, we go through this simple 12-step process to assure the data, and it can take anywhere from a couple of weeks to several months to say this refreshed data is acceptable for use. One of the things that you have to live it to understand is the data is not so easy. The data is not your friend. So here's an example of the unexpected. This is perfectly normal looking data from one of our data partners. The data were refreshed, so new data was added at the end, and then data that had been perfectly well behaved in the last refresh is suddenly gone. And you could fix it, but unless you paid attention every time, suddenly the second quarter of 2009 is not there. There's always an explanation. It's never an interesting explanation, but so anyway. But in order to make a system that's actually useful to FDA and gives the answers, gives the real answer to the question you think you were asking, you needed to be able to sort of devote these kinds of resources to it. Now, there are some who say that's the problem with claims data, and when we get to EHR data, we won't have those problems. And in our experience, nothing could be further from the truth. Because we have decades of experience working with claims data and figuring out how to regularize it, whereas the EHRs are, for all the really important progress the Office of the National Coordinator has made, I'd say EHRs are still the Wild West. I mentioned that we now have laboratory test result data for about 10% of our population. Every laboratory test result is a struggle. These are the units of measure for platelet counts. There are 60 of them in our data. This isn't, we went out and surveyed the literature. We said in our data what is there. So laboratory test result by laboratory test result, there is a work group that's thoughtful about what's in the data and what can we use. Why is this, you say? It's because even the large national labs were built as legacy systems from many regional labs. Almost all of these results are perfectly reasonable ones to have, and every clinician would be able to use them. So it's not a problem in delivery of care. It is only a problem when you try and repurpose the data for this kind of activity. The New York Times called this the data janitor work of big data, and we wear that with pride, I want to say. We have really internalized the importance of protecting private personal information, but we can't show you what's in our hearts. So I'll just show you that we have said we're not interested in individuals' data. What we want is the information that lives in that data, and so we're looking for answers to questions rather than personal data. I'll also mention that it's really hard to take a selfie of your back. Now, the principal way in which we preserve privacy is by not moving individuals' data around. The data, as Janet said, lives in a distributed data set, which means the data lives with the organization that already has it. And what they do is they make a copy of a portion of their data, put it in a standard format, keep it under their own control, and then the operations center sends them an executable program that runs on that data, gives a result, they send the result back. And this is this particular method that we're using to do that is one that our team that Jeff Brown leads has developed. We were really pleased the Office of National Coordinator designated this as a reference standard for its query health program, and the system itself is getting used for other kinds of purposes. It's of course open source software. So that's the data part. On the methods front, as Janet said, we really need to be able to use state-of-the-art methods in this environment, and many of the state-of-the-art methods really weren't built for that purpose. So we work in these 6 large domains, and I won't read them off, and underneath these are some bullets representing the kinds of work we do there. But as a general statement, I'd say something like 90% of our methods work is adapting methods rather than developing new methods. And also, as Janet said, there's a life cycle for developing methods. As we start with methods experts saying, we say to the methods experts, here's a problem we'd like to solve. And they say, this is a technique that might be useful. And it sort of starts with a literature review about what's available. And then we move through these 6 steps of developing a production tool. The 6th step never ends. That is, it's tool enhancement, because once we put these into production, it becomes clear that you'd like to improve them in a variety of ways. So that's a substantial amount of work. We're also doing a fair amount of work just trying to be clear about how do you define, it's always clear how you define, well, it's often clear how you define an exposure to a medical product, but it's not so clear how you define either the outcomes that you're interested in, or you can define them in conversation. How do you find them in the data systems that we have, or in defining the things that you need to adjust for? Because people exposed to one product aren't like people who are exposed to another product if you're trying to do a comparative assessment. Or there are a range of people exposed to a single product, and you'd like to know whether people who are in one category have a different experience than people in another category. And so let's loosely call those confounders. And so we've done a substantial amount of work trying to standardize the operational definitions. Diabetes, there are lots of ways to define diabetes, and so we want to be sort of consistent with the best definitions that are available for the uses that we have in mind. So sometimes you want a very broad definition of diabetes, make sure you capture everybody. Sometimes you want to be very specific, so you make sure that you have just people who have type 1 diabetes that's been treated in a certain way. So a lot of work summarizing the literature. Fair amount of work validating that in our systems, and then making sure that we keep track of what we've learned and what we use. So building these libraries has been a considerable amount of work. We've also put a fair amount of work into creating a taxonomy for which techniques are appropriate for which exposure outcome relationships. And this was in no small measure because Janet said it seems kind of mysterious that every time the agency asks you a question, you say, we'll take it under advisement and tell you what we think the right way is to do it. And so that turned out to be a very useful thing to do, Janet, because it made us be much more thoughtful about this. And so this is like everything else. It's a guide. It's not sort of a prescription for how to do things. But it's been very helpful for us to think about which techniques, and then what we need to build out, because it helps us and FDA say where are the major uses going to be. We've put a lot of time and energy into developing these reusable tools. The first set are the ones that are on the left here. That is, for the past several years, we've been talking about what we call modular programs, reusable programs that'll organize data in a certain way and tell us and the agency how many people are there who've had various kinds of exposures, what are they like, and to some extent what happened to them. So we now call that cohort identification and descriptive analysis. We've put an enormous amount of energy in the past couple of years into this middle column now, actually being able to do comparative analyses in a routine way, something that has been a very labor and time intensive way, and are building out in the right-hand column the ability to use those sequentially. Now, the reason that this diagram is built this way is the output of the cohort identification modules now directly feeds the analytic adjustment modules, and the analytic adjustment modules feed the sequential analysis and signaling activities. And the ones in green are the ones that are operational now, and the ones that are in white are the ones that we're still developing. I'll give you a quick example of the cohort and identification and descriptive analysis. So this looks, we've seen this before. It's possible to in a straightforward way, describe the population, describe the people who are new users of a specific product in a particular time period with a whole variety of inclusion and exclusion criteria. So you can be very particular about who you want to be studying, and the ability to do that has gotten better over time, and then the ability to specify the outcomes with a bunch of options. What's for us new and quite exciting is is making operational the ability to do quite sophisticated adjusted comparisons between products. And so to illustrate that, I'm going to show you an example that we used 2 years ago, because this was our first comparative analysis of that. It's what we call a protocol-based analysis. A team got together, thought for a long time, and wrote a lot of code and answered a question in a way that we hadn't been able to do before. Almost 4 million antihypertensive, 4 million new users of blood pressure control medicines, propensity score matched analysis, and no person level data was shared. And we said this was great, and I was particularly pleased to say the coding took 5 months, cost $250,000, and the reason that was a big success was before we had developed these capabilities, doing a study like this was millions of dollars and years of work, a time frame that was never useful to FDA. They'd call up and they'd say, can you study this? And we'd say, in 6 weeks we'll tell you if we can study it, and if the answer is yes, we'll tell you after it's no longer useful to you. But with this new tool that we've stood up, all you have to do is fill out the specification forms. And so I'll show you a few screen grabs of, the first one says, what do you want to study? What time period do you want to study? What analytical tool do you want to use? Oh, what's the age group? And some other stuff. And then there are a couple of screens of defining the exposures, talking about who you're interested in and what the exposure time should be. A little more stuff about if a person stopped treating, can they come back into the and then restarted? Could they be eligible again? If they had a short break, how short a break can they have? How long a break can they have? Blah blah blah. I won't show you the other 12 screens, but you specify the outcomes, you specify the inclusion criteria, you specify the exclusion criteria. You say I want to adjust for these things, and then you have a bunch of propensity score matching options, and out pops table 1. Table 1 tells you that there were 3.9 million users. And the ones who got the ACE inhibitors were really different from the ones who got beta blockers. They were more likely to have diabetes, they were less likely to have heart failure, and they were less likely to have ischemic heart disease. Clinicians will know that that's entirely expected because there's a reason that clinicians would do that. So the question is, how do you make a fair comparison between them? Well, so propensity score, and just by the way, the program also gives you the histograms of the propensity scores, and you can see that there's a tail over to the right of people who've been exposed to the ACE inhibitors for which there's really no match in this. So when you do the propensity score matching, 2.6 million people end up being matched. So you give away some people, But on the other hand, now on diabetes, heart failure, and ischemic heart disease, there's perfect balance, which is what you'd like to have, and the histogram is now indistinguishable from the two groups of almost complete overlap. So that's table one. That's table two. It gives you confidence that now you're making a comparison that's fair, at least with the things that you're looking at there. And table three comes out, and table three shows you that the propensity score matched hazard ratio is 3.1. And by the way, what did we get when we did the formal protocol-based analysis? It was 3.0, which is as close as you can get without cheating. And what did this take? We can now do these analyses in weeks, not months. And we don't have a formal accounting, but think tens of thousands of dollars rather than hundreds of thousands of dollars. So thank you for bearing with me during that discussion, but we think that this is, in many ways, changes the game in terms of what we can offer FDA for doing analyses that really inform the decisions that they want to make. I'm just listing here briefly the work groups that are working on data, on methods activities. Some of them are in making the understanding and enhancing our use of data, and some of it's in developing statistical and analytic tools. Just say that in the last year, we've been delivering a couple reports a week to FDA on questions of interest. Marcia and Michael will sort of talk about the protocol-based analyses we're doing with the Center for Drugs and the Center for Biologics. These are analyses or work that is beyond the ability of these reusable tools, but it's a full slate of work that's we think stands up to substantial scrutiny. And I'll just go a level deeper on the plans for Sentinel that Janet described. So we already have 3 new data partners that are sort of actively engaged as part of the Sentinel contract. We also, the last line here, let me just say, PCORNet has created, PCORI, Patient-Centered Outcome Research Institute, has created PCORNet, a national resource to do comparative effectiveness research. There are 11 clinical data research networks, and they're all part of the new Sentinel contract. Our plan is to have them become active after the transition to Sentinel. So I can't introduce you to them here, but here are the organizations that are leading those clinical data research networks. And as Janet mentioned, we're in discussion about working with the federal data partners or working with CMS data. We also have some new academic partners who bring specific kinds of content or methodologic expertise in pharmacoepidemiology. We now have a larger patient advocate committee. Steve Makita is, we were delighted that he was willing to continue to work with us. Patrick Lake has rejoined, and Sharon Terry, who's here and will be speaking later, is also part of the team now. We're really delighted. We're expanding the common data model, and we will be working pretty hard to be able to work with EHR data. Just want to point out that there are a lot of different kinds of EHR data, and one of the reasons we're particularly pleased about being able to work with Hospital Corporation of America is it gives us insight into what happens during a hospitalization, and that's something that we haven't really had good granularity for. And so the fact that we will, by the end of this year, be able to talk in some detail about what happens inside a hospitalization for a meaningful fraction of U.S. hospitalizations is really very exciting. So the world's changing around us. What about ICD-10? So the good news is the team that architected our data systems made it ICD-10 ready. So no problem there. All we have to do is learn how to use it. And so we've got a fair amount of work going on to be ready to use ICD-10 when it shows up. And we've got some important methods priorities. It's how do we do this linkage with the National Death Index? These production tools that we've developed, we've put them through a fair number of paces, but we want to do a very robust assessment of their operational and statistical performance so that we understand if they have limits, we understand where they are, and we're talking particularly with IMEDS about how we might partner on that. Bunch of things we want to do to make these prospective tools work better. We want to be more thoughtful about how you follow up a signal. If you get it, what happens when something comes up and we can't explain it away, and how do we deal with that? And finally, as I mentioned, we're starting to put real energy into trying to extract as much information as possible to find signals, even if we don't know how to look for them. On the national resource front, Marcia Reichman has led a very interesting program of partnering with local public health agencies around how we would monitor the use of medical countermeasure agents that might be used. We're engaging with a bunch of organizations, Clinical Trials Transformation Initiative, PCORNet, as I mentioned, the NIH Collaboratory. Just want to show you a couple examples. One is with the Clinical Trials Transformation Initiative, we took Janet's good advice to think about how the resources and capabilities that Sentinel's developed might support clinical trials, and that work's gone extremely well. Last year we posted a white paper that's it's way longer than anybody would want to read, but we have recently completed some test runs to see how this might work, and we're extremely optimistic that there's a huge amount more to do, because this is a public health activity and Sentinel isn't a clinical trials network, and the organizations haven't signed on to doing these. There's a bunch of things to do, but the basic concept is it's possible to use this very large population for which you have good data to identify, first of all, to understand what the rates of various kinds of outcomes are to plan for a clinical trial, and secondly, even to identify practices, hospitals, individual members who might be appropriate candidates for those trials. I'll just say that we have the we have the honor of leading the coordinating center for PCORNet, and which is designed to do comparative effectiveness research, and we're working hard to make the PCORNet infrastructure and the Sentinel infrastructure be code compatible. And then we found ourselves in the catbird seat developing a distributed research network for the NIH Collaboratory. Shh, don't tell anybody, the NIH Distributed Research Network at the moment is basically the Sentinel partners facing the NIH. So our schema is one infrastructure serving multiple important purposes. So there's Sentinel, there's PCORNet, there's the CTSA, Distributed Research Network, and for our perspective, the beauty part is the organizations get to choose whether they want to participate in any particular organization or not, but each network can have its own governance. So Sentinel is public health practice, but work that PCORNet or the NIH do would obviously be research covered by the Common Rule, and IRBs would oversee it. The networks, though, get to share the infrastructure, because there's this is a big investment for the for us taxpayers, and so we see this as a win for everyone, and we're really pleased to see we've made a substantial amount of progress on that. I'll close just by saying that in many ways we've made more progress than I think we had reason to hope for at the beginning, and I think there are a few things that have made that possible, but the most important of them has been the really extraordinarily positive partnership that we outside the FDA have had with the folks at the FDA, and the partnership that's developed between the organizations that have data and expertise and organizations that don't have data but bring a different kind of expertise. And in my experience, this is extraordinarily rare. And as I don't know whether it's a byproduct or it's a necessary precondition, we've enjoyed working together. So I won't read through the rest of these things, but I will say that I'm sure you're all wondering what happens to the logo. And the answer is, we don't know for sure. So I'd say it's not time to get the tattoo yet. But, so thank you for letting me share this.
Thanks, Rich. I was going to ask about the next tattoo, but Marcia is going to speak next. Marcia Reichman is the Senior Advisor and Scientific Lead for Surveillance Programs at the Office of Surveillance and Epidemiology in the Center for Drug Evaluation and Research. We've heard a little bit from Rich already about her many contributions to Sentinel-related efforts, as well as the overall post-market surveillance activities at FDA. And turn over to you now.
Thank you. How do I find this? Great. Okay. Thank you. It's a pleasure to be here today to talk about our accomplishments under Mini-Sentinel and how we're moving forward. I'm going to present an overview of the spectrum of assessments that we've done in CBER under Mini-Sentinel, talk a little bit about how the resulting data is being used, and then I'm going to emphasize two particular assessments, and these relate to work that we've completed and also some of the ways in which we expect to move forward under Sentinel. The NDI Plus linkage has been mentioned by both Janet and Rich. And so this is a way that we hope to ascertain out-of-hospital death and cause of death. And it will really expand our data sources. And as I'll mention as I talk about it, it has implications not only for post-market safety surveillance, but for pre-market work as well. And then I'll also talk about a tool that we've developed for evaluation of medication use during pregnancy. This has been developed very recently, and I'll talk a little bit about how we came to work on this and how this is leading to, right now, the development of a very reusable but not production-level tool, which we expect under Sentinel to convert to a production-level tool. So just briefly to sum up, and this data is actually as of September of 2014. In the past 5 years, we've performed in CBER about 200 summary table requests for over 650 data items, and about 150 modular program requests for over 250 data items. The prompt assessments, which I'll talk about later, which are a semi-automated way of incorporating aspects of adjustment for confounding and other types of complex statistical analyses into a very rapid turnaround tool. We have 3 that are ongoing, and probably another 3 or 4 more that are being planned or in the very beginning stages of implementation. We have 9 protocol-based assessments, essentially full epidemiologic studies that are underway or that have been successfully completed, the first of which was the angioedema study that Rich talked about. So how do we see the enhancements over time in what we call modular programs, but really started as a very simple tool and now are extremely complex and sophisticated? So the complexity of safety scenarios. We've seen real changes in what we can put into these queries in terms of pre-existing conditions, concomitant treatments, and complex outcomes and exposures. So if you remember the timeline which Rich showed, we can put many, many more events onto that timeline as we form a query and come much closer to what's actually happening in the real world. When we started 5 years ago, we defined outcomes as lists of codes. Now we can define outcomes really with complex logic and different alternatives and put them into one modular program, which is a tremendous advance. In terms of analytics, when we started, we had stratification of different groups by age or sex, but now we have adjustment for confounding, and we can do things as complex as propensity score matching in the time frame that we have been used to working with for a modular program, which is weeks, not months. We can also do sequential analyses so that we can look at a drug that comes onto the market at various times after its approval and do sequential analyses and statistical testing at each of these steps. So the prompt tool gives us a semi-automated design to incorporate a lot of these enhancements into a single tool and to allow us to do secondary and sensitivity analyses. This slide with very small print really gives a long list of selected complex assessments that use multiple or enhanced modular programs. And you can look at this at your leisure. In the interest of transparency, we'll post all of the results from these, almost all of which I think have been posted already, as soon as the analysis is complete. These include a wide spectrum of questions, not all of which have to do with a potential safety concern. Sometimes we'll look to see if a particular cohort has enough members for us to ask questions about them. As has been mentioned, we'll look to see whether we can see known associations, whether they're positive or negative, and whether we have the ability in this data set to look at certain outcome definitions and have confidence that that outcome definition is giving us a reasonably complete ascertainment. The prospective routine observational monitoring program tools have been available for us to use probably for about 4 months or so. You can see listed here the 3 analyses that are underway, and as I mentioned, there are additional analyses in the planning or implementation stage. And we can use this tool for a one-time assessment, as we did with niacin in fibrates with an outcome of severe bleeding, or for sequential analyses as we're doing in the other 2 cases. This slide lists the protocol-based assessments that have either been completed or underway. They cover a wide spectrum of activities. And I'm going to talk more in detail about the use of drugs during pregnancy and the potential for identification of sudden cardiac death through linkage with NDI+. So how are we using the results? So I'll mention that a number of the queries that we do really don't show up here because they confirm something that we were really expecting. That really goes to show that lots of other pre-approval processes are working the way we hope they do. There have been 2 drug safety communications coming from CBER, one looking at dabigatran and warfarin with outcome of severe bleeding, and the other olmesartan with sprue-like enteropathy. And these differ. So in the case of the dabigatran drug safety communication, this was very early surveillance, and this modular program was really the focus of the drug safety communication. In the case of olmesartan, there were a number of other sources of data. The signal was first seen in FAERS. There were de-challenged, re-challenged studies. There were case series. This has been spoken about before, but it also gives one example, I think, of how this collaboration works. We realized from the FAERS data that there was a latency period of these symptoms of about 2.5 years. And the first modular program we did looked at all exposure. And so then we were talking with our colleagues in the Mini-Sentinel Operations Center, and Nicola Balliot, who's here, actually pointed out that we would be able to do a modular program that looked at outcomes that occurred starting at various times after exposure. And this gave us the data that contributed from Mini-Sentinel to this drug safety communication. So the results have also appeared in many safety reviews mandated under Section 915 of FDA, in advisory committee presentations and track safety issue reviews. These are some of the cases, not all of them, and I'm not going to go through the individual situations here. We've also done some evaluation of FDA regulatory actions, a lot of studies looking at LABAs. Another example is looking at prasugrel and clopidogrel and its use in various patients. We've looked at drug use to look at uptake of NMEs, to look at how long after a drug comes on the market in various classes of drugs and various individual drugs we can really start to perform surveillance, and also in a number of other situations. So I'm going to switch gears a bit and talk about identification of both death and sudden cardiac death using linkage with NDI+. This slide shows a number of members of the work group, but really not everybody who's been working on this project. So Mini-Sentinel currently obtains death information only if a medical claim or administrative data is generated. So standardized information on out-of-hospital death and the cause of these deaths is highly desirable, particularly for sudden cardiac death, which I'll talk about in detail, but also for suicide and other outcomes. And we get asked about these outcomes frequently, and right now our answer is we just can't really do them. So there's a potential for linkage with the National Death Index Plus, which has both death and cause of death, from the National Center of Health Statistics, the CDC. This is a centralized database of information that comes from the state death record information. So retrieval of an NDI death record and matching with an individual person depends on a linkage that's based on personal identified information, on Social Security, first and last name, month, day, year of birth, and sex. So why did we choose sudden cardiac death? And actually, this whole project came from OMD groups who are interested in looking at this particular outcome. In drug development, QT studies can be required as part of an NDA submission to assess the risk for proarrhythmia, since QT prolongation is a marker for this risk. So this approach is reasonably successful, but it has a number of drawbacks that are listed here. And so the question came up, could we look at this issue reliably in the post-market period? So algorithms do exist and can be developed or enhanced to investigate a number of specific causes of death from death certificate information. So in particular, Wayne Ray and colleagues have an algorithm which has been published and validated in Medicaid data for looking at sudden cardiac death. So in this project, what we're doing is, the long-term goal is to create a standard process for matching to NDI plus data by linking selected cases to this data. In this case, what we want to do is to identify cases of possible death in 4 cohorts, and then to submit information on those individuals to NDI Plus and retrieve the cause of death. So these cohorts include individuals who are users of antiarrhythmic medication, which would have an increased sudden cardiac death risk, a general population, which compared to the first cohort would have a lower sudden cardiac death risk, users of selected antibiotics, and users of selected antidepressants. So the status at the moment is that protocols are being reviewed and finalized. A survey of data partners has been completed, both to see their willingness to participate in this and also the availability of data that's needed for linkage. And this has been really very optimistic. We've gotten very positive response. We're also in the process of defining the programming specifications for selection of individuals to help data partners submit this information to NCHS for linkage, since the way the linkage would be done is through the individual data partners in NCHS, because they would have to take the de-identified Mini-Sentinel distributed database information, link it to PHI, so that it could be sent to NCHS and linked to the NDI+. NCHS will then send back a list of probabilistic matches to the individual data partners, and then they would use a program developed by the Mini-Sentinel Operations Center to adjudicate those matches and decide which would be retained and which would not. And then the retained matches would again become de-identified and move into an analytic process. And so the last part of this is that we're in the process of completing an application to NCHS to get approval for this linkage. So to switch gears again, I'm going to talk about evaluation of medication use during pregnancy in the Mini-Sentinel distributed database. And this is a list of working group members. So the need for routine post-marketing surveillance on current medication use during pregnancy is well recognized. In prior studies in the U.S., it's been reported that the majority of women who are pregnant use at least one prescription medication during their pregnancy. Right now, there's no comparable size population which has and will have moving forward current data on drugs that are used by pregnant women. So in all of the work that I'm going to talk about, we've defined pregnant women by those who delivered a live infant. And then we've worked backwards using various algorithms to define the period of pregnancy. And so how did we come to start this? So again, this was a request from our colleagues in O&D, and there was a request from an advisory committee for information on current drug use during pregnancy for several classes of drugs, some of which have been associated with problems with the infant, and some of which are associated with reactions among pregnant women that might affect the pregnancy. So the objective is to assess medication use among pregnant women who deliver a live-born infant and a comparison group of non-pregnant women in the Mini-Sentinel data. We want to make this tool reusable so that going forward, we can monitor drug use at various times for a population of drugs we know we want to watch, but also for other drugs where issues come up over time. And so right now, this is a reusable tool. One of the things we want to do moving forward is convert it to a production level tool so that the turnaround time is very rapid. Also, we want to examine drug use among pregnant women who have certain pre-existing conditions that are defined by diagnoses, procedure, and drug codes. So the study population is women aged 10 to 54 who delivered a live-born infant between the years of 2001 and 2012. And we're looking at pregnancy episodes for which women were continuously enrolled in a health plan with pharmacy benefits for at least 480 days before the admit date for the delivery. And in some circumstances, we also want them to have coverage for medical claims as well. So there's a comparison group of non-pregnant women with similar eligibility criteria, and these are randomly matched from those with matching criteria on a one-to-one basis. The pregnancy start and end dates and the periods of the trimesters of pregnancy are based on an algorithm that was developed under the MEPREP project and also based on ongoing work that's being done in CBER. The characteristics of pregnant and non-pregnant cohort are being examined, as is the prevalence of medication used by gestational period, by year of delivery, and by maternal age. And as mentioned, the SAS code for this program was developed so that the program is reusable. And also the additional capabilities that we're interested in terms of looking at pre-existing conditions and gestational age category, including codes for preterm and post-term birth, are included in this program. So this slide shows maternal age at delivery. It compares this Mini-Sentinel cohort, which numbers over 1.5 million pregnancies, to U.S. live births in the year 2012. And so you can see that, by and large, the Mini-Sentinel population is a bit older in some age groups, that the percent of preterm birth code is lower, and the percent with a post-term birth code is also lower. So there are some differences from the general U.S. population. This slide shows medication exposure during pregnancy. And so you can see, for instance, that for SSRIs, the percentage of pregnancies where women took these medications goes down, particularly as you look towards the third trimester of pregnancy. You can see also for anti-diabetics that in the third trimester of pregnancy, the use is increased, and that likely represents gestational diabetes, and we're looking in more detail at the use of these drugs. The next slide just shows some additional information which you can look at later when you see the slides. So the strengths of this are to have a large geographically and demographically diverse population. Looking at the data this way avoids recall bias, which would come from individual reporting. And the analytic tool is readily adaptable to provide timely information on use of different medications during pregnancy, and also allows us to look at different pre-existing conditions. So the limitations are that there's an inability to ascertain, as there is in all observational data, whether women really took the medication. All we know is that they picked it up. There's a lack of data, of true data on gestational age, so this is done by modeling. There's no information currently on pregnancies that did not result in a live birth. As a follow-up to this, we hope to look at other pregnancy outcomes. And also, there's no linkage to infant records, so that we can't look at any direct effects on the infants, but really that was not the objective in formulating this tool. And we found that the first use of this tool was a couple of months ago, and we've had probably 4 or 5 different queries come to us for further reuse of this tool. So I think it's making quite an impact. And I'll stop there. Thank you very much.
Thanks very much, Marcia. You covered a lot of ground. So I'd like to turn now to Michael Nguyen, who's the Deputy Director of the Division of Epidemiology in FDA's Office of Biostatistics and Epidemiology at the Center for Biologics Evaluation and Research. And I'm going to talk about some of the CBER-related applications of Sentinel. Thanks, Michael.
Thank you. I'm delighted to be here. I speak on behalf of many, many hardworking and talented folks, I think both at FDA and at the Mini-Sentinel Operations Center. Just to name a couple, Steve Anderson and David Martin and Estelle Russick-Cohen and Scott Winicky and Bethany Baer, who just have been really, really instrumental in the success of our program. And that's not counting the long, long list, too long to name, at the Operations Center, our list of investigators like Betsy Krishillis and Megan Baker and Catherine Yee. So it's great. It's great to be here. Just to give you some context, although this is the 7th meeting, CBER's program's been going on for about 4 years for vaccines and 3 years for blood products. So we've had our time frame has been a little bit shorter. So, all right, without further ado, I'm here to really talk about how Sentinel has impacted the work that we do every day. So I want to talk about specifically the role of Sentinel within the product life cycle at CBER. I'd like to map key Sentinel studies that we've launched to date onto that regulatory life cycle. I'd follow with really trying to illustrate Sentinel's impact on every single major phase of post-licensure safety for us. And not only our current impact, but almost everything we do is a stepping stone to building a better system and looking forward for future impacts. So I'm going to start with a very, very simple timeline, a regulatory timeline. The story for us, and obviously there's a ton of work that happens before this, which I'm not going to detail, but the story for us starts at filing, when a manufacturer submits an application to us for licensure. And between the filing phase and the approval phase, well, for the time being, I'll just call it the pre-approval phase. And this is an important time point for us because we start to we get a good first glance at the data and start planning for what we're going to do after licensure. After that, after approval, the next key data point really is the post-market safety review. These are congressionally mandated, so they're important, but they're also important, I think, scientifically, because the moment you have the approval for a new medication or a drug is the moment that you know least about its real-world performance. And so you gradually get a better and better understanding as it's used in a more heterogeneous population, and when it's used in the messiness of the real world that may not use it exactly as it was studied and used in the clinical trial setting. So these two post-market safety reviews, which I'll talk about later, the Section 915 and the Pediatric Advisory Committee safety reviews, represent the earliest key time point for us in post-licensure safety. And so that early post-approval phase, which I'll just name here for convenience, is really important for us. And I'll show you later on how Sentinel impacts that phase. Of course, then there's the rest of the life of a product, and for the convenience sake, I'll call this later post-approval. So this slide is the tree on which I'll hang all the Sentinel ornaments to follow. All right, so I gave you a basic timeline. So let's talk just about that first phase, that pre-approval phase, where a lot of energy is being targeted towards planning for after licensure. This is essentially a risk management function, and it starts with gauging your level of concern for a product. So there's, for convenience sake, I'll say that there's 3 levels of concern here. There's the sort of routine level where you're really satisfied with the adequate and well-controlled studies that come with the BLA, and you look at the data and there's nothing surprising. It acts how you expect it to act. And so in that setting, we're perfectly comfortable with using the tried and true passive surveillance for VAERS and FAERS that's been proven effective and is a strong foundation, good safety net. Let's say that you have a desire to further describe the safety profile. You want a little bit of extra reassurance because this is a brand new product. Let's say a vaccine with a brand new adjuvant that you don't have any experience with in the United States. Or a blood product, a factor replacement that is manufactured in slightly a different way than using some new recombinant technology. And so you're just concerned about it. The data are fine and you're satisfied, but you just want a little bit more reassurance. And before Sentinel, we used to do post-market commitment studies. A lot of these are pregnancy registries, general safety studies, things like that. And then there's the last, where you find something that is concerning in there. You have a signal. It's uncertain. You don't know the significance. You don't know if it's real, but it's worrisome enough that you want follow-up investigation. And that's where, at least since FADA was implemented, we now have the ability to require a post-market study. So this is the landscape. This is our set of options in the pre-approval phase before Sentinel. Now, after Sentinel, you're just awash in more and better options that really fortify the strong foundation that we started with. So with passive surveillance, now you can do modular programs, which we've talked about quite at length, and I'm not going to go into further on this. We also have things like tree scan, which I'll talk about in just a moment. We've talked about the prompt and the near real-time surveillance. So we're not waiting for the data to accumulate and then doing a retrospective study. We're looking as the data come in to make sure that there's nothing unusual popping up. So you take pregnancy registry studies, and now that we used to do, and now we can do dedicated protocol-based pregnancy safety studies in Sentinel. And then obviously we have like autoimmune studies. More on this, and then if you have a safety signal, now you can do a targeted outcome study in Sentinel. So what you're seeing is that Sentinel substantially expands the post-market safety monitoring options for FDA to allow more strategic and tailored surveillance of new drugs and biologics. Now, I want to pause a moment because I'm going to have a lot of slides like this where I'm going to show a before and I'm going to show an after. And I want to make sure that the message is coming through here that I'm here to talk about the promise of Sentinel. I'm here to show you just how much this is going to transform FDA. At the same time, I don't want the message to come across as this is the panacea, this is going to address all of our problems, and that actually we don't need the set of pre-Sentinel options. In fact, I would say that you need the entire table here to have a strong pharmacovigilance system, because Sentinel is not going to be able to address every question coming out of the BLA phase. We are going to have to rely upon the age-old PMC study and negotiate with the sponsors, and there's still a role for PMCs, and I'll say there's still a role for PMR. So it's not a panacea, but there's a lot of promise. The second message is that we've made a lot of progress. We've made an enormous amount of progress, and that's what I want. I'm going to go phase by phase and talk about that. At the same time, I don't want the message to come through that there were problems before Sentinel, that our decisions were unwise before Sentinel. And so, how can I say that? How can I say that? I'll say that Sentinel is successful because it grows out of the precursor ideas out of the old system, right? So the general safety studies that we used to do for vaccines, all we did was we took that precursor idea and we took it into Sentinel, and we grew it, we made it more robust, and we made it more sophisticated. So really the ideas, the creativity under the old system was always there. And so we're not grafting on this Sentinel idea. We're growing it organically out of FDA's existing system. So, all right, enough on that. Let me turn to signal detection with tree scan. So this is something I'm really excited about. So this graph is random data generated in Excel. It's fake. And it's for any outcome you want. Let's say it's myocardial infarction. Counts are on the y-axis, days after exposure after whatever drug you want to say is on the x-axis. We used to have to pre-assign a risk window to do an analysis, right? So in this case, we do 1 to 21 days. The problem is if you get it wrong, you miss the signal. If the true signal is 6 to 10 days, you're going to dilute it and miss the signal. If the true signal or the true association is 18 to 24 days, you're going to miss it. And so what do you do about this? Well, Martin Koldorf, the genius that he is, has come up with a solution. And that is, what happens if we choose a risk window and we scan it across the entire time period of interest, right? Good. So now we're trying to find unusual clusters that we would have never thought to detect. All right, well, let's change the risk window again and run it across the entire period and do it again and again and again. And you can start to see now, without pre-specifying a risk window, you start to be able to maximize the utility of the data. And so what this method does is it identifies unusual clusters after exposure using a variably sized scanning risk window. Okay, so that's pretty good. Okay. Well, let's scale this up for outcome B, outcome C, outcome D, and outcome E. And you start to see the effect of this. and now we use this on thousands of outcomes. None of them are pre-specified. None of the risk windows are pre-specified. And you can do groups of outcomes because you've organized this on a tree of, based on organ system and pathophysiology. And the method intrinsically controls for the multiple testing for all these thousands of events and all these hundreds of risk windows evaluated. So there is tremendous, tremendous potential here. It's still being built, though. I would say if this were a house, the walls and the structure are up, but we're still working on the plumbing and the electrical. We're also going to build an infrastructure to follow up all these alerts, because obviously you're going to get signals. You don't know what to do with them, and we have to create really a protocol for how to handle these and how to investigate them. Okay, so an amazing, amazing potential. What's even better than that is that this is available free online, right? So here's the Mini-Sentinel website. Here's a link to the tree scan software, which gives you a link to the tree scan website, which gives you a link here to the to download the analytic program, and then there's technical documentation on how to use it. So what we're building for everyone, and I think it's just really, really one of the remarkable things about Sentinel. All right. So I've given you a lot of framework. I've given you a lot of like wonkiness and talk and things like that. Let me give you a real example to put meat in the bones, okay? So December 10th, 2014, just a couple weeks ago, FDA approves Gardasil 9 for the prevention of certain cancers caused by 5 additional types of HPV. So a follow-on vaccine. Here's the pre-approval phase, right? So here's the sponsor's pharmacovigilance plan for Gardasil 9. They organize it in the normal way. There's identified risks, which you can call known risks associated with the product. There's potential risks, risks where we're uncertain whether it's true or not, but there's some evidence to suggest it. Then there's missing information. Okay, so here they've listed in the identified risks hypersensitivity reactions, exposure to pregnancy. Obviously, there's always an exposure to pregnancy risk if you're giving this in women of childbearing age. Then there's syncope causing injury. For potential risks, there's Guillain-Barré syndrome, and then obviously missing information is there's unanticipated adverse events. You can never predict it. And so they always have an action plan, and this is what we evaluate. Is it adequate? Is the plan proportional to the adverse event and proportional to the likelihood of that adverse event, the certainty of that adverse event, the seriousness of adverse event? So they suggest routine surveillance, and then they're going to actually do a pregnancy registry. Perfect. Sounds great to us. For Guillain-Barré, they're going to do routine pharmacovigilance. Great. Sounds great to us. For unanticipated adverse events, they're going to build this on top with an observational study of 10,000 folks. I think that sounds great. I think we can do better. And here's how we can do better. So these are Sentinel enhancements to the sponsor's Gardasil 9 pharmacovigilance plan. We will now do a general safety study. We will take that awesome, awesome tree scan program and implement it to detect serious and unexpected adverse events. We're going to do real-time surveillance for pre-specified outcomes, and then we're going to do an autoimmune surveillance study. This is an observational retrospective study to evaluate immune-mediated conditions that are theoretical safety concerns common to all vaccines. So the key here, why is it called general safety? It's called a general safety study because it's in that section, that middle bar of the pre-approval phase where you just want extra approval. You just want extra reassurance. There's no clear signal coming out of the clinical trials, but you want that extra layer of safety net. And we'll also do a pregnancy outcome study. So both of these proposed studies seek to enlarge the existing safety database and monitor safety in the real-world healthcare setting. So I'm looking forward to seeing the results. All right, so that was Sentinel's impact on the pre-approval phase. Now let's turn to the early post-approval phase, and we'll turn specifically to these 18-month post-market safety evaluations. So there's two. There's a Section 915, the Pediatric Advisory Committee. I'm not going to go into extreme detail on this, but Section 915 happens once in a product's lifetime. It includes all ages, all adverse events. It happens at 18 months or 10,000 exposures, whichever is later. So there's the time period when you do it is actually a little bit variable. Only the conclusion is posted online. the bottom line. With Pediatric Advisory Committee, it's only pediatric, obviously. It happens at 18 months, but it happens 18 months after every indication for a pediatric, a pediatric age indication. So if they add a new indication and it impacts the pediatric population, you come back to the PAC. And the full analysis is presented online publicly. And it's presented to a committee, and they get to vote. They vote, and they give us input. And so it's a very rigorous, time-consuming process, and that's why we take it seriously. So what's the impact on these 18-month safety review? Well, for the most part, pre-Sentinel, we had VAERS and FAERS. That was the majority of the data, because it's only 18 months of data, and all you have is passive surveillance. I mean, yes, there's PMCs and PMRs that come through, but usually there's no data by 18 months. There's manufacturer safety reports, PSURs and PARs, and then there's literature, but usually 90% of the data is FAERS and FAERS. Well, now you have the option that by 18 months after licensure, you now can do a tree scan. You now have data coming out that's from prompt. You can do modular programs. You have real population level surveillance, real rates coming out, all being presented at this key time point of 18 months after licensure and affecting the 915 and affecting the PAC. All right. So, so I just detailed how Sentinel impacts getting into the 915 and getting into the PAC. But actually, at the PAC, you can launch a Sentinel study, right? This 915, we did the 915. We saw something funny, and we wanted to follow it up. And so, from the 915, we launched a Sentinel study here on Kawasaki disease and PCV13. Okay, another one. This is an example coming out of the PAC. So we went to for Gardasil, we went to the PAC and presented all the data. Well, the PAC then said, we saw that you presented a non-statistically significant elevated risk for venous thromboembolism, and we'd like you to follow that up. Before Sentinel, we didn't have a way to do that. Now we do. Now we do, and the results are back in this, and we hope to publish, put them online very shortly. All right, so the last phase, later post-approval. There's lots of options later post-approval because you have a lot of data at that point. And this is just a great project. It's a methods project on strengthening the evaluation of the safety of vaccines administered during pregnancy, a very key population for us. And what I talked about scanning risk windows before and identifying unusual clusters. Well, this does it in 2 dimensions. This does it by looking at gestational age at the time of vaccination, and you're looking at the time since vaccination. And both at the convergence of the green and the blue is not in this version because this is all randomly generated data, but that's what you're trying to find is the convergence of those both 2 dimensions and looking for unusual clusters. So just an amazing project. We're also enhancing the core data that's coming out of our health plans. We're developing immunization linkages to immunization registries and linkages to birth registries to really fortify the core data coming out of health plans, make them better. And it's easy to say, oh, we link with 8 registries, birth registries, and 8 immunization registries, until you realize that every single relationship is a bilateral relationship that has to be negotiated individually. And all the data has to be done, checked individually. And then you start to think, wow, 8 linkages to 8 data parts, that's a lot of work. Okay, so we're not all about vaccines. This is all posted online. This gives us our public timeline. So we have all 13 studies that we're doing, the date at which we expect the protocol to be posted or when it was posted, and the final report date. I just wanted to highlight that we're looking at immunoglobulins and we're looking at Trolley, and so it's not just all vaccines. And we're slowly growing this portfolio. And I'll say second thing that as I mentioned before, there's no study that stands alone, and the meaning of the results stands alone. And Trolley is a perfect example. Yes, we want to know what the rate of Trolley is after blood components, but Trolley represents so much more to us because it represents the integration of Hospital Corporation of America, and it's the creation of this inpatient database to allow us to look at all of the blood components, all of the plasma protein derivatives and therapies that to this point it's been challenging to study So the trolley study means so much more to us and is really the future of our blood program. Okay, so last two slides, I think this is essentially mapping it all and it's summarizing all. So we're developing tools for every need. Again, the pre-approval strategic planning phase, it allows us to think ahead. In the early post-approval phase, you already get data. Prompt, tree scan, modular programs, and you can continue those if you want to. Then later post-approval, so after 18 months, you get that targeted outcome study, you get autoimmune studies, and you get pregnancy safety studies. And so this slide shows the impact on the CBER medical products so far. So which products have actually gone through this new system? Well, Gardasil 9, Bexsero, and Termenda. And so we're looking forward to see how these new general safety studies help us monitor these new vaccines. And then obviously there's all the existing work that we've done. And I won't go into it because I'm out of time. All right, so summarize. Sentinel has integrated into routine post-market safety regulatory process at CBER. It's been going on for a while. Sentinel has impacted both the pre-approval planning stage and the post-marketing phases, both of them. And we're developing tools for signal detection, refinement, and evaluation. The majority of our CBER products have a twofold impact. They address an immediate regulatory concern, but they also build an infrastructure and advance methods for future studies. And we're working on it steady to apply Sentinel to all classes of CBER-regulated products, not just vaccines, but blood components, plasma protein therapies, and then really the toughest one, which is our human cells, tissues, and cellular and gene therapies. So we're making steady progress, and I think we're going to get there. Thank you so much.
Thanks very much, Michael. Very much appreciate your comments. So heard three very extensive presentations on not only where Mini-Sentinel's been and where Sentinel's going and Rich's tattoo plans, but also how the Sentinel infrastructure is, I think your words were really transforming post-market activities generally. This is a time for questions and comments, and I think we've got can you help me out with where the microphone's in the back? So let's try to get a couple of those up to where people who have questions can use them. So while that's happening, let me just ask one question on this post-market surveillance kind of transformation that's taking place now. You all have been very clear and eloquent of the additional possibilities for generating evidence that have come with these Sentinel capabilities. I wonder if we could get some comments from one or more of you about your sense of the impact of these new tools on the cost of doing post-market surveillance, not just the benefits. And there has been, just as there's been a sort of a previous infrastructure, as Michael was describing, for what was available with FAIRS and other pre-existing tools, post-market studies by manufacturers. There has been an infrastructure there before. How does this fit with the post-market studies, with the kinds of things that data partners can and have, and I think will be doing on their own, not through the Sentinel initiative?
Well, FDA invests something between $10 and $15 million a year just in creating the infrastructure to support this kind of work. And then it's a great bargain after that. I mean, so the question is sort of amortizing that investment over a sufficiently large number of studies. But protocols. So one of the reasons we're so pleased about these modular programs that can do propensity score matched analyses is those used to be hundreds of thousands of dollars, even in the Sentinel. So before Sentinel, they were millions of dollars. I mean, we've, I see Elizabeth Andrews nodding there, because we are survivors of that period when each study was custom built. We would build lovely houses using hand tools, and they took a long. They were good, but they didn't help very much, and they were very expensive. So the protocol-based analyses now cost a few $100,000 if you don't have to review records, and if you do have to review records, they can cost up to $2 million. That's still a very expensive thing to do to be able to access the records and redact them and get them adjudicated and then integrate the results. These modular programs, at the moment, the very sophisticated ones cost tens of thousands of dollars. Our hope is to drive that cost down by getting better at doing them and by having a sufficient volume of them. So, and things like these summary table lookups that Marcia mentioned, the marginal cost of those is almost zero. So,
Janet.
Sure, I'd say from the taxpayer's perspective, this is probably going to be a bargain. But we have put a large amount of money, in investment money, both appropriated dollars and user fee dollars into building this system. But I think the next 5 years we'll start to see the cost effectiveness. So we're kind of at that tipping point where you can hear that it's providing capabilities we didn't have before, but of course we just didn't spend the money before either because we just didn't get the information. So, it's the return on investment I think will really start over the next 5 years, and I think we are committed to doing that, although we hope, as Rich talked about, that with other uses of the data network, that we can do some cost sharing in the future with other parties who want to use the data for other purposes.
And for the tools that have been developed, I know a lot of these are public use. Have they had an impact on what the data partners are doing on their own and their own ability to support studies that involve the same type of data methods and the like?
I think we're just getting ready to at least to the extent that I know about it, we're just getting ready to sort of see that sort of broader use outside of Sentinel. Let me just sort of scan the crowd. Some real experts in the crowd. Anybody have a non-Sentinel use of these yet? Okay.
That's coming up later today too. I had a question up here from Merrill.
So I'm Merle Weinberg, and I'm CEO of the National Health Council. I wanted to ask Rich if you could share a little bit more information about the Patient Advocate Committee, because we've talked about that over years. Just what their charges are, how you engage them, and for what purposes.
Well, part of the transition plan is to rethink the way that committee is going to operate, because it's been a single representative to date, and that single representative has been part of our. The overall coordination and leadership belongs to a planning board that has representation from each of the partner organizations, and first Bray and then Steve have been members of the planning board, so sort of participate as equals there. They vote on that, but we recognize that it's a big load for one person to represent all patients, and so that's why we want to have a committee, and we'll sort of work with them on a new charge in a way to really have them stand up separately. Oh, could I just amend my answer about other uses?
Okay.
Is that all right? The NIH has, through the NIH Distributed Research Network Collaboratory, the NIH has actually just given us a small amount of money to begin to use those tools, and we've sort of surfaced a couple of questions that they're interested in asking in that network environment. So if you want the update in a couple of months, we can tell you sort of what questions they settled on and who participated and what the answers are.
Great. Other questions? Anna?
Thank you. I enjoyed all the presentation. Can you hear me?
Yeah, that's good.
Yes. Okay. Thank you for all the presentations and for the work. I work intensively with the data, and I troubleshoot, and I am touching problems. For example, in the study where you look at ACE inhibitors and angioedema, you didn't pick up signals for the angiotensin converting enzyme inhibitors that are also associated with angioedema. Then the comment, it's very difficult to analyze the data, and if we analyze the data once, it's even more difficult. We have now a lot of experience using clinical trial data that we can reanalyze the data multiple times and it's done in seconds, then and it's healthy to be able to look at each other's work and look exactly at the intersection to be able to find problems with the data. Then, we need to audit each other's work, I think.
Yeah, these are, and it's the general issue of, these are complex questions. These are not, it's impossible to do clean, randomized studies on all of the kinds of issues that you all have talked about here that are important considerations in safety, not to mention effectiveness. And I know this is going to be an ongoing challenge and one that's getting a lot of attention. So, Janet.
Yeah, well, CBER is building a data warehouse for the clinical trial data, and in a couple years or something like that, we negotiated a few years ago, once we put out guidance on the data submission types in the pre-approval submissions and marketing applications for the raw data, that then we could require everybody to submit it in a standardized format. And of course, we have to give people time. But we already have that database, courtesy of the National Cancer Institute, who collaborated with us, and we're putting the data in there. So eventually, we'll be able to make more bridges across what was done in the preclinical, or in the pre-marketing side and the post-marketing side, if that's one of Anna's points. Yeah.
Do you expect some of the same kinds of steps that Rich and others went through in terms of developing common data models and being able to do comparisons, or is this going to be more straightforward?
It's more straightforward because many of the data standards are being developed now, even for each disease, with the collaboration with the industry, CDISC, CFAST, the CPATH Institute, and a whole bunch of other parties for clinical trials. So you can standardize data. You can constrain a lot of the data elements in clinical trials, although for the adverse events, that's of course less the case. We are doing all that, and we would expect to have large data sets over time that are actually analyzable from the pre-market clinical trials, and also pre-market exposure experience that might not be clinical trials. So eventually this will all come together in some mysterious way. But we are developing tools, and we have a large tool set for that data warehouse to analyze those data.
Well, I want to thank our panel for the presentations today. A lot of ground to cover, and a lot going forward, and especially for all the work that all of you all have done to do what amounts to this transformation of post-market surveillance. Thank you all very much.